For decades, the standard treatment for severe peptic ulcer disease was entirely mechanical. Surgeons physically removed sections of the stomach or severed its nerve supply to force a reduction in acid production. Modern proton pump inhibitors have largely replaced these aggressive operations. Yet these procedures remain heavily tested cornerstones of surgical anatomy and board examinations. To master this topic, you need to understand three specific areas: the precise anatomy of gastric reconstructions, the neuroanatomy of the vagus nerve, and the timeline of postoperative complications. Altering the continuity of the upper gastrointestinal tract is a deliberate trade-off. By physically rerouting digestion, surgeons create highly predictable and testable physiological deficits. The stomach sits high in the supracolic compartment, featuring a wide lumen that rapidly narrows as it transitions into the proximal duodenal tractus. When a distal gastrectomy is performed, the first option is a Bilroth 1 reconstruction. The surgeon partially closes the wide-cut edge of the stomach, so it perfectly matches the diameter of the narrower duodenal lumen, creating a direct end-to-end gastroduodenostomy. This is only viable if the two ends can be joined without tension. If a larger portion of the stomach must be removed, the gap becomes too wide. Pulling the duodenum up would create dangerous tension. Instead, surgeons perform a Bilroth 2 reconstruction. The duodenal stump is permanently sealed shut, and a distinct loop of jejunum forms an end-to-side gastrojejunostomy. Food bypasses the duodenum, moving directly into the jejunum, while biliary and pancreatic secretions travel from the stump to mix downstream. The decision between a Bilroth 1 and a Bilroth 2 is an anatomical compromise. You are trading the physiological ideal of duodenal transit for the mechanical safety of a tension-free anastomosis. A third approach, the Roux-en-Y reconstruction, offers a complete gastrojejunal diversion strategy that builds upon the concept of the closed duodenal stump. Instead of bringing up an intact loop of bowel, the surgeon measures exactly 50 centimeters distal to the duodenojejunal junction, physically transecting the jejunum. This creates two limbs. The distal segment, the Roux limb, is anastomosed to the stomach. The proximal segment, carrying pancreatic juices, connects further downstream. This Y-shaped configuration forces ingested food to travel a considerable distance through the Roux limb before it finally meets the digestive enzymes from the biliopancreatic limb. Delaying this mixture induces testable malabsorption and weight loss. While initially a consequence of ulcer surgery, this precise physiological deficit is intentionally co-opted as the functional basis of modern bariatric gastric bypass. Translocating the jejunum introduces a distinct mechanical challenge. The stomach resides in the supracolic compartment, while the jejunum is infracolic, separated by the transverse colon. Routing the jejunum anterior to the transverse colon leaves a space behind the Roux limb where bowel loops herniate, creating a Peterson's hernia. Alternatively, routing posterior to the colon requires passing through the transverse mesencolon. Herniation through this specific defect produces a Steamer's hernia. Every surgical rerouting strategy inevitably generates an anatomical dead space. Because of this, internal hernias remain a high-yield diagnostic consideration anytime a post-gastrectomy patient presents with acute abdominal pain. Before modern acid-suppressing drugs, surgeons managed severe ulcers by performing a vagotomy, the physical severing of the vagal fibers that stimulate parietal cell acid secretion. Navigating the anterior vagal trunk requires identifying the gallbladder branch, the pyloric branch, the anterior nerve of Latarjet, and terminal crow's foot branches. Rotating to the posterior vagal trunk reveals the criminal nerve of Grassi. Missing this branch leaves persistent innervation, causing recurrent ulcers. Severing these main trunks effectively stops acid, but it also denervates the pyloric motor supply, causing profound gastric stasis. Therefore, truncal vagotomies universally mandate a concurrent drainage procedure, like a pyloroplasty, to manually widen the gastric outlet and prevent food retention. Surgeons eventually developed the highly selective vagotomy. By only cutting the crow's foot branches, stopping the denervation exactly 7 centimeters proximal to the pylorus, antral motor function is preserved, entirely eliminating the need for a drainage procedure. This matrix maps 3 primary vagotomy procedures against their clinical outcomes: acid reduction, ulcer recurrence, and complications. Highly selective vagotomy yields the least complications, but suffers the highest ulcer recurrence rate. At the other extreme, a truncal vagotomy combined with an entrectomy provides the maximum possible acid reduction, but carries the absolute highest complication burden. Surgical acid modulation is a zero-sum game. The surgeon must continuously balance neuroanatomical selectivity against clinical efficacy. Post-gastric surgery patients face highly predictable nutritional deficits. Iron deficiency anemia is the absolute most common nutritional complication, typically presenting as microcytic hypochromic anemia, fatigue, and pallor. Vitamin B12 deficiency has a distinct presentation. Because hepatic stores last for years, this deficiency appears much later, characterized by megaloblastic anemia, coupled with strict neurological manifestations. The anatomical alterations also create distinct mechanical vulnerabilities. A duodenal stump blowout occurs in closed stump procedures around postoperative day 4, when pressure breaches the sutured closure. Additionally, afferent loop syndrome occurs when a proximal limb stricture causes dark bile to accumulate and distend the upstream segment, leading to severe bilious vomiting. Directing gastric transit into the jejunum also risks marginal ulceration. The delicate jejunal mucosa entirely lacks the inherent neutralizing mechanisms that protect the duodenum from direct acid exposure. Bypassing physiological sphincters creates an environment of unregulated transit. This exposes unprotected mucosa to acid and turns blind limbs into high-pressure zones. The single most frequently tested postoperative complication is dumping syndrome. It is driven entirely by the loss of pyloric regulation and the unregulated transit of carbohydrate-rich chyme into the small intestine. Early dumping syndrome occurs 10 to 15 minutes post-meal. Dense hyperosmolar carbohydrate particles enter the jejunum, causing surrounding intravascular fluid to rapidly shift across the intestinal barrier and flood the bowel, causing severe physical distension. This sudden fluid shift triggers bloating, severe nausea, and vasomotor symptoms. While most conditions might resolve with rest, these symptoms intensify if the patient continues to eat. This graph plots blood glucose and insulin levels over time to illustrate late dumping syndrome, occurring 30 to 40 minutes post-meal. A rapid spike in blood glucose triggers an exaggerated spike in insulin, which then drives the glucose line crashing downward into the hypoglycemic threshold. This rebound hypoglycemia manifests as headache, sweating, and tachycardia. Unlike early dumping, these symptoms uniquely improve upon eating again. For board exams, keep this distinction clear. Early dumping is an acute mechanical fluid shift, whereas late dumping is a delayed endocrine overcorrection. The management of dumping syndrome follows a strict stepwise algorithm. First-line treatment relies entirely on dietary modifications. Patients must consume small, frequent, high-protein and high-fat meals, while completely avoiding liquids and simple sugars during ingestion. If strict dietary changes fail, the clinical pathway escalates to medical management using octreotiner. Ultimately, if severe symptoms persist, the surgeon may consider a surgical conversion to a Roux-en-Y architecture to intentionally slow down gastrointestinal transit. Success on this topic requires flawlessly differentiating the anatomical structures of the Bilroth 1, Bilroth 2, and Roux-en-Y procedures. You must map the exact complications of vagotomy, predict internal hernias based on anticolic versus retrocolic routing, and distinguish the precise osmotic and endocrine mechanisms that drive dumping syndrome.